Welcome to our discussion today, where we'll delve into a critical topic, head injuries. We'll be drawing from the comprehensive insights found in the Neurologic Disorders, Chapter 14, Head Injury Material. Alex, to begin, how would you define a head injury, and why is understanding it so important, especially concerning children?
Well, Chloe, a head injury at its core is any injury resulting from mechanical force that affects the cranium, scalp, meninges, or the brain itself. Its importance, particularly with children, is starkly highlighted by the fact that unintentional injuries are the leading cause of death in children over 1 year of age. This makes rapid identification and understanding critical.
That's a sobering statistic. When we talk about different types of head injuries, what are some of the key distinctions we should be aware of, beyond the general definition?
Certainly. We often hear terms like concussion, which is a mild traumatic brain injury that temporarily alters how the brain functions. Then there's a contusion, which is essentially bruising of the cerebral tissue. A more severe injury can be a laceration involving actual tearing of the cerebral tissue. And, of course, there are skull fractures caused by direct trauma to the skull, which can take various forms.
Skull fractures sound quite varied. Can you elaborate on the different types? Are some more common or more dangerous than others?
They definitely are. Most common are linear fractures, which are single fractures beginning at the point of impact and not crossing suture lines. Then there are depressed fractures, where bone fragments are pushed inward. Comminuted fractures involve multiple linear fractures, often from intense or repeated impact, which can unfortunately be a sign of abuse. Basilar fractures occur at the base of the skull. Open fractures involve a break in the scalp or mucosa, increasing the risk of infection like osteomyelitis. Finally, growing fractures are particularly concerning as a fracture worsens due to pressure from brain herniation, dilated ventricles, or a cyst.
The implications of these fractures are significant. Given the potential severity, what preventative measures should people be aware of to minimize the risk of head injuries?
Prevention is paramount. It boils down to simple yet crucial safety practices. Wearing helmets is essential for activities like skateboarding, cycling, riding ATVs or motorcycles, skiing, and contact sports. Seat belts are non-negotiable in cars. Avoiding dangerous activities such as driving under the influence or cycling at night without lights also reduces risk. Crucially, we must emphasize never shaking a baby, as this can cause severe head trauma. And for children, proper installation and use of car seats are vital.
The never shake a baby point cannot be overstated. Beyond prevention, when an injury does occur, what are the primary risk factors that increase the likelihood of head injury, and what initial findings would alert us to a potential problem?
Risk factors often include a lack of supervision, inappropriate or absent safety practices, and improper use of safety devices like helmets or seat belts. When assessing a patient, we look for a history of the injury event, including any reports of dizziness, headache, double vision, or vomiting. Amnesia, either before or after the injury, is also a key finding, as is any alcohol or controlled substance ingestion.
Those are clear indicators. Moving to physical assessment, what are some observable signs, especially concerning a person's consciousness, that point to a head injury, and how did these signs evolve as an injury progresses?
Loss of consciousness is a significant indicator, and its duration is critical. For minor injuries, we might see temporary loss of consciousness, confusion, vomiting, pallor, irritability, lethargy, or drowsiness. As an injury progresses, we observe more marked changes, significant alterations in vital signs, a clear change in mental status, focal neurologic deficits, and increased agitation.
And when an injury becomes severe, increased intracranial pressure, or ICP, becomes a major concern. What does that look like, particularly in different age groups?
Increased ICP is a serious complication. In infants, you might see a bulging fontanelle, separation of cranial sutures, irritability, restlessness, increased sleeping, a high-pitched cry, poor feeding, or distended scalp veins. In older children, common signs include nausea, headache, forceful vomiting, blurred vision, increased sleeping, and inability to follow simple commands or a decline in school performance and seizures. Late findings are particularly alarming, involving alterations in pupillary response, posturing, bradycardia, decreased motor and pain response, abnormal breathing patterns like Cheyne-Stokes respirations, and eventually decreased consciousness or coma.
You mentioned specific types of posturing. Can you describe flexion and extension posturing and what they signify about the brain injury?
Absolutely. Flexion posturing or decorticate posturing indicates severe dysfunction of the cerebral cortex. It presents with the arms, wrists, elbows, and fingers flexed and bent inward onto the chest, while the legs are extended and internally rotated. Extension posturing, or decerebrate posturing, is even more serious, signifying severe dysfunction at the level of the midbrain. This involves a backward arching of the legs and arms, flexed wrists and fingers, an extended neck, a clenched jaw, and sometimes an arched back.
Those sound like critical signs. Are there also specific physical findings tied to the various types of skull fractures you mentioned earlier?
Absolutely, there are. For a depressed fracture, the skull simply appears misshapen. With basilar fractures, we might observe blood behind the eardrum, subcutaneous bleeding over the mastoid process, or around the eye orbits, what's known as raccoon eyes or battle sign. Crucially, there could be leakage of cerebrospinal fluid from the nose or ear. Open fractures will show tissue laceration over the fracture, often with possible CSF leakage as well. Growing fractures are insidious. They might present with a skull defect or scalp edema, and neurological changes like headache, hemiparesis, seizures, or intellectual difficulties can emerge months to years after the initial injury.
The delayed effects of a growing fracture certainly underscore the need for long-term monitoring. Once a head injury is suspected, what laboratory tests and diagnostic procedures are typically used to assess the full extent of the damage?
Initial lab tests include arterial blood gases, blood alcohol and toxicology screenings, a complete blood count with differential, liver function tests, serum electrolytes, and a urinalysis. For diagnostics, cervical spine X-rays are crucial to rule out spinal injury. Computerized tomography and magnetic resonance imaging of the head and neck are often performed, with or without contrast as indicated. An electroencephalogram, or EEG, can assess for seizure activity.
And how is intracranial pressure actually measured? What are the critical thresholds for concern?
The expected reference range for ICP is 1 to 10 millimeters of mercury. A level greater than 15 millimeters of mercury requires immediate further assessment and intervention. From a nursing perspective, a significant part of managing head injuries involves stabilizing the spine until a spinal cord injury is ruled out. Constant monitoring of vital signs, level of consciousness, pupils, ICP, motor and verbal responses, often using the Glasgow Coma Scale, is essential. Maintaining a patent airway is critical, which might involve mechanical ventilation. We also carefully monitor oxygen saturation levels.
Beyond monitoring, what are the specific actions taken to manage and reduce increased ICP, and why are these measures so important?
Implementing actions to decrease ICP is fundamental. This includes keeping the head midline with the bed elevated to 30 degrees to promote venous drainage. We must avoid extreme flexion, extension, or rotation of the head and maintain a neutral position. It's also important to keep the client's body in alignment, avoiding hip flexion. Minimizing oral suctioning and strictly avoiding nasal suctioning is key, as these can increase pressure. We also instruct clients to avoid coughing and blowing their nose for the same reason. These measures prevent any activities that could further elevate pressure within the skull, which could lead to further brain damage or herniation. We also need to implement measures to prevent complications of immobility, like turning every 2 hours, maintaining footboards and splints, and inserting an indwelling urinary catheter. Administering stool softeners prevents straining, and providing a calm, restful environment helps manage the client.
It sounds like a delicate balance. What about medications and therapeutic procedures used in these cases?
Medications include mannitol, an osmotic diuretic given intravenously to decrease ICP and cerebral edema. Antiepileptics are used to prevent or treat seizures. Antibiotics might be necessary for CSF leakage, lacerations, or penetrating injuries. For pain, acetaminophen is often used, and sometimes morphine or midazolam. As for therapeutic procedures, they range from less invasive options like transfontanal percutaneous aspiration to more involved ones like subdural drains, burr holes, or even a craniotomy, where part of the skull is temporarily removed and then replaced when swelling resolves. Surgery is also performed for depressed fractures to elevate the bone fragments.
That's a comprehensive overview of the interventions. Finally, what are the most severe complications that can arise from a head injury, and what are their manifestations?
The complications can be life-threatening. An epidural hematoma involves bleeding between the dura and the skull. Classically, it presents with a short period of unconsciousness, followed by a normal, lucid period, then a rapid decline into lethargy or coma due to blood accumulation and brain compression, and vomiting can be present. Subdural hemorrhage, bleeding between the dura and arachnoid membrane, often results from falls or violent shaking, and if retinal hemorrhages are also present, child abuse must be considered. Manifestations include irritability, vomiting, increased head circumference, lethargy, anemia, and seizures. Cerebral edema or brain swelling can develop within 24 to 72 hours post-trauma, leading to increased ICP and changes in cerebral flow. The most dire complication is brain herniation, a downward shift of brain tissue characterized by loss of blinking, loss of gag reflex, pupils failing to react to light, Cushing's triad, which is systemic hypertension, bradycardia, and respiratory distress, and eventually coma.
Those are incredibly serious outcomes, underscoring the critical need for prompt and accurate management of head injuries. Thank you, Alex, for shedding light on such a vital and complex topic, drawing from the Neurologic Disorders, Chapter 14, Head Injury Material. Understanding these distinctions and interventions can make a life-saving difference.
My pleasure, Chloe.